The annual American Society of Hematology meeting is just a big event. This year, it's anticipated that there were over 30,000 registrants for the meeting, which is a new record for this event. And it's just hematologists from the world over. Over 115 countries are represented. So really, it's just the nexus of what's going on in blood diseases overall. And so it's always an exciting time to meet up with colleagues and see what the latest and greatest is that's happening here, not just for MPNs, but across hematology. Specifically for MPNs, there's a lot of exciting research that was presented here at the meeting. There's a session also for education, just about MPNs in general and different topics within MPNs, and I gave one of the talks there, and the focus of the talk was JAK-STAT inhibition and beyond. So we all know about ruxolitinib and Packrat Nib. They're out there, commercially available, and available to use for patients, which is fantastic. But what's beyond that? How do we go past that? And really, honestly, in the context of a 25-minute discussion, you really can't talk about every individual promising agent that's being developed right now. So what I really set out to do was give a framework for the folks in the audience, starting with, well, why is JAK-STAT inhibition important? What are the medications that have been developed, and what were the clinical trials that led to their development, and how well do these drugs perform, and when do they fall short? And so hopefully with that explanation, then the audience could then go out and see all these abstracts, see the posters, listen to the oral presentations, and really understand and put into context the research being presented here at this meeting over the past few days. So it really, hopefully, kind of sets the stage for that. Again, there are a large number of abstracts that were presented at this meeting. Over 6,000 bits of scientific information, many of which were about MPNs, both ET, PV, as well as myelofibrosis. Particularly, a number of abstracts were presented looking at new therapies. I know in a series of videos here, they were covered. There were two drugs that are in development, which I presented results for. The first one is a drug called luspatercept. The whole idea of luspatercept is to improve anemia in patients with myelofibrosis. Anemia is a big problem. 40–50% of patients with myelofibrosis will have anemia, and many will develop it over the course of their disease, both from the disease getting worse, as well as from treatments like JAK inhibitors. So luspatercept is looking to change the tables on anemia. There are medicines already out there that can improve anemia, like ESAs, or erythropoiesis-stimulating agents, danazol, and IMiDs like lenalidomide. But these often fall short. Luspatercept is exciting because it works on a different mechanism to promote the growth of these red blood cells and alleviate anemia. So this clinical trial really set out to explore different types of patients and where we could improve upon their anemia. And there were four major bins of patients in the study. There were patients who were anemic but not needing transfusions. And there were patients who were needing regular transfusions from their anemia. And those two groups of patients were not on ruxolitinib. And there was a second larger group of patients who were on ruxolitinib. Those who didn't need transfusions and those who did, but were still anemic. So really four bins of patients: off ruxolitinib, off ruxolitinib, and those not needing transfusions and those needing transfusions. So when looking at the results of the study, it's kind of hard to say because there's four different groups with multiple endpoints, and it gets really complicated. I think this take-home point is we definitely did see improvements in anemia in all of these groups. Perhaps we saw the most improvement in patients who were needing transfusions and were on ruxolitinib. Overall, the medication seemed to be safe. There were very few adverse events or side effects from the medication. The three most common side effects were elevations in blood pressure, bone pain, and diarrhea. But overall, it was a very well-tolerated medication. And this information from this study is really going forward to inform a larger clinical trial that may hopefully someday lead to approval for this medication, and then thus commercial availability for patients out there across the country. The second study I presented was on a medication called Packrat Nib. Packrat Nib is a JAK inhibitor, similar in some senses to ruxolitinib or fedratinib, as it is a JAK inhibitor and inhibits JAK2 specifically. It also has off-target effects on other molecules like FLT3 and IRAK1, which may be important in the formation and the way myelofibrosis grows in the bone marrow. This study included patients who were both previously treated with ruxolitinib and those who were not. So it could be either or. previously treated with ruxolitinib in those who either didn't have an optimal benefit, didn't really get a lot of improvement, or had some improvement and then it didn't keep working for a long period of time, or those patients who couldn't tolerate the medication either because of a side effect or low blood counts. This drug is important for patients because it's targeting a population of need. So if you look at ruxolitinib and you look at fedratinib and you actually open up the piece of paper that the FDA puts in with the medication about prescribing based on platelet counts, it doesn't include in that package insert, as we call it, instructions for prescribing this medication for patients with platelet counts less than 50,000. And these medications haven't been extensively studied with large randomized trials in those populations. So it's certainly an area of need. Packrat Nib in randomized controlled trials have shown to improve spleen sizes and symptoms in patients with these low platelet counts, again, below 50,000. Although early on in the clinical development, Packrat Nib was put on a hold by the regulatory authorities over concerns of bleeding events and cardiovascular events. But these holds were lifted later on when more information came in, and then the development of this medication could proceed. And out of that is this PAC-203 study, which was really a study to look at different dose levels and find the optimal mix between efficacy, or how well the medicine works to relieve symptoms and spleen size, and safety. And at the end of the day, the best mix of efficacy and safety was seen with this 200 milligrams twice a day dosing level. And so that's the level that's been chosen to move forward in a randomized phase 3 study called the Pacifica study that'll be launching shortly. Another piece of information and piece of research that I presented here at the meeting was looking at real-world data for patients who are taking ruxolitinib. So, we have the COMFORT studies, the studies that led to the approval of ruxolitinib. But most patients are not treated on a clinical trial. You go and see your doctor makes a diagnosis and deems that this treatment is appropriate for you, and you get prescribed ruxolitinib. And a lot of that information is not always looked at, of how these drugs perform out in the quote-unquote real world after a drug's been approved. So what we did is we used a large medical claims database. It's a medical claims databases are these databases that are made out of insurance claims. And so we can kind of track what is prescribed for patients and how much their healthcare costs are and what medical interventions they're getting over time. And again, one of the major key inclusion criteria for this study were patients who are not on a clinical trial. We really want to focus on real-world patients out there in the community. And we saw that the doses of ruxolitinib were kind of all over the map. And a large number of patients were getting very small doses, probably limited a lot by cytopenias. Almost 70% of the patients who were at the lower doses of ruxolitinib were anemic. And many of them were also thrombocytopenic, meaning low platelet counts. We tried to compare the two groups, those who had higher doses of ruxolitinib versus those who had lower doses of ruxolitinib. And higher doses were anywhere from 30 milligrams in a day, so 50 milligrams twice a day, up to the normal 20 milligrams twice a day, or even 25 milligrams twice a day, so all the way up to those maximum doses, versus those who had less than 30 milligrams of ruxolitinib a day, so patients who are on 10 twice a day or 5 milligrams twice a day. The groups seem to perform similarly well, but two key differences. In patients who are on these lower, maybe suboptimal doses of ruxolitinib, we saw that they ended up being on ruxolitinib for a shorter period of time, and they may be incurring more healthcare costs. Now, this was not a complete look at what the healthcare costs were that were associated with that treatment, but there were some indications that they had maybe more ER visits or more ER costs and pharmacy costs. So you wonder if how that plays out. And that's really, again, points out another population of patients with myelofibrosis that's difficult to treat, and really emphasizes back to my original point that we need new treatments. We need to push the field forward, and not to belittle the importance of JAK-STAT inhibition, but we need to go beyond these treatments that we have and find new treatments for patients and to really improve their outcomes. And that's really just what the point of this meeting is to take a big survey of what's going on in the field, see the latest and greatest, and really you walk away with a sense of how much work people are putting into improving the lives of patients with MPNs. And I think that's what makes this meeting really, really special.